Dr. Hemant, good evening. Dr. Rahul, good evening. Shall we start? Rahul, unmute yourself, please.
Yeah, I am in another meeting, so I'll be just joining with you in a moment.
No issue. Hemant, shall we start? Dr. Sant? Okay. Good evening, everybody. Today we are going to have yet another Friday night case presentations by neurology residents. And Dr. Sri Hari from Bharti Hospital will be presenting a case. So, Dr. Hari, can you put it on slideshow and start?
Yes, sir. Good evening. Today I'm presenting a case of a 27-year-old female. She was a right-handed individual, educated up to 7th grade, a resident of Pune. She used to work in Mumbai as a cloth and utensil washer. Hindu by religion and history was given by herself reliable. She presented with the chief complaints of pain in hands, legs and neck since 4 years and weakness in her legs, hands and neck since 4 years.
So, you can go slowly so that others can follow.
Yes, sir. My patient was all right 4 years ago when she developed pain in her legs. It was insidious in onset, a deep aching type of pain. Initially started at the thighs and calves while doing her daily work. It worsened at work and was present throughout the day. There was associated cramp-like sensation in the painful areas. The pain used to improve at night when she used to go to sleep. There was no radiation of pain or any associated swelling. The pain was not worsening on coughing, sneezing, or standing for long, and it was not relieved on application of hot or cold. Over the next 3 months, it gradually progressed, and she was unable to wash utensils and clothes for long like before because of the pain. It was now present over the arms and neck region also. It was associated with weakness. There was difficulty. Initially, she noticed difficulty while using the toilet. She developed difficulty getting up from the squatting position, needed to place her hand in front to support herself while getting up. She also developed difficulty climbing up and down stairs. She said she needed support of the railing to do so. There was no history of slipping of slippers. She says that she feels looseness in her legs and arms. She also developed a fear of falling and felt that her legs were weak. So she started walking slower and cautiously, and also complained of associated gait instability while walking. The next 3 months, she noticed difficulty in hanging clothes overhead for drying after washing and removing them. She also had difficulty placing and removing clothes from the cupboard. She earlier used to carry about 2 buckets of water while going to wash clothes, which became 1 bucket in the last 1 year. And then over the next 6 months, she was unable to do it. And she also felt her fingers become stiff during the activity, and she had to ask a colleague to help her. There was no difficulty holding cups, pens, buttoning or unbuttoning her clothes. Simultaneously, she was unable to get up from the bed also like before. She has to turn her body to one side and hold the side of the bed and lift her body upwards to sit up from a lying position. Similarly, while going to sleep, she used to let go of her body after sitting on the bed and then drop down onto the pillow. She also noticed thinning of her arms. She felt that her blouse became loose and also in her legs, in the calves and thigh region. There was no muscle twitching that was noticed over the body. 6 months back, because of this difficulty, she had to quit her job and she's not able to wash clothes like before. She now stays with her husband in his ration shop and maintains the ledger. There's no history of loss of consciousness, forgetfulness, headache, vomiting, or seizures. No visual symptoms, no loss of facial sensations or facial deviation. There's no difficulty swallowing, drinking water, or eating. No episodes of nasal regurgitation or choking. There's no history of urinary bowel disturbances. No history of any sensory level in the body or loss of sensations. There's no history of profuse sweating, palpitations, dryness of mouth, giddiness episodes. There's no history of fever, loss of appetite, night sweats, or bony pains. Weight loss, she has not checked, but clothes have become loose. There's no history of chest pain, breathlessness, abdominal pain, melena, hematochezia, altered bowel habits, or any blood in urine or red colored urine. No exposure to chemicals or pesticides. In past history, there's no history of diabetes, mellitus, hypertension, tuberculosis, bronchial asthma, ischemic heart disease.
Go back to first slide.
Yes, sir.
Anybody wants to ask any questions so far in the history before he summarizes? Do you want to have any more idea about the first part, localization history? That is, where is the problem in the neuraxis? Or in the second part, what could have caused this? This is a story of 4 years. Anybody wants to ask any question? Any doubts? Dr. Sant sir, anything you want to ask?
Sir is muted.
Muted and asked to
Yeah,
unmute.
sorry, I would like to ask if it was symmetrical, asymmetrical.
So it was symmetrical.
Symmetrical. Okay. Anybody else wants to ask? There are two questions here. One is a pain in hands and weakness in legs. Dr. Arohi, can you tell what type of pain he has described?
Yes, I think the pain is dull aching, non-irritating, localized in the thigh, more in the proximal region, usually.
And you think
And does not.
it is from which place? Is it from the radicals, nerves? What do you think it is?
So not a radicular pain because non-radiating, not in a specific direction, and it does not aggravate or worsen with any other features. It's
So,
more of a funicular pain if we
now you are
localize it.
treading on a wrong path. What are the characteristics of funicular pain?
Dull aching, continuous pain.
Dr. Teja Garapati, can you tell? Purva Reddy will ask you. No? We are now interacting so that others can join. Okay. Apurva Reddy says it is a deep pain. Any other characteristics of funicular pain? Chinmay? Okay. Funicular pain originates from? You can unmute and talk. It's not from roots. We are asking a question. She said funicular pain. Achha, you are talking about cramps. So let us finish off this first one. What is funicular pain? Where is it originating from? Tracts. Which tract? Which tract? Which tract? Posterior. Posterior columns, you are saying. Funicular pain originates from spinothalamic tract. It is a dull, boring type of pain which is ill localized. It is there, but you don't know where it is. So that's a characteristic of funicular. So Arohi, do you think it is funicular pain?
No, sir, it's a localized pain.
It's a muscular. It looks like a musculoskeletal pain. Okay.
But there is no regulation on cold and hand application because of no inflammation, but looking like a muscular localized pain.
Okay. Then what is the second part of the history? Hari, you can show the next slide.
There was an associated cramp-like sensation.
Yeah.
Then she developed weakness. Also, the pain was present. Then gradually she developed pain over the arms, neck region also. Started in the legs and then in the arms and then the neck bilaterally.
So we have concluded, could it be because of musculoskeletal region? We don't know. Then, if it is musculoskeletal origin, what could be the cause for this pain?
myopathic
సౌండ్ రావట్లేదు ఏంటి
Please, no cross talk. Venkatesh, can you tell? Unmute yourself. Dr. Hemant, do you want to say something? Okay, Hari.
Yes, sir.
Carry on. So, what this pain is? What could it be? Is it anything to do with metabolic causes? Metabolic, inflammatory, myositis, mitochondrial. That's nice. So, which metabolic cause could you think?
So metabolic, they usually have pain after exercise. And sometimes they develop like second wind phenomenon, where initially they have pain and weakness, and then after exercising for a bit, then they regain the strength. Then in severe metabolic myopathies, they might have associated myoglobinuria.
So one cause is metabolic, and mitochondrial. Does mitochondrial myopathies have pain? I'll say again.
Yes. Yes, sir. They have more symptoms at rest, like because of increased requirement of it. When there is increased requirement of ATP because of oxidation problems, because of the mitochondrial defect, they will develop sweating and all the weakness at rest also in mitochondria.
So we are faced with two problems. One is a pain, that is second is weakness. So
Yes.
can anybody characterize the weakness? What type of weakness is this? Originating which part of neuron?
Initially proximal.
Hari, you stay back. Somebody else can answer this question. Anybody can answer? What type of weakness? You can go on showing the slide slowly so that they can read again.
Yes.
Proximal, lower and upper limbs. Okay, that's one. So is originating from where? Is it muscle, neuromuscular junction, nerve, plexus, radical, roots, symmetric? That's Dr. Sant has asked that question. So it could be muscle pain. Okay. So one cause could be the weakness of muscle. So what are the parts that are involved? By the history.
Yes, initially the hip muscle, hip region weakness. Then after that, she's developed weakness in the proximal, like shoulder region. So she's not able to remove clothes and hang them overhead for drying. So both shoulder and hip region weakness.
Okay.
Then later she developed distal weakness also because she's not able to carry the bucket of water that she was carrying. And
so somebody asked, could it be polymyositis? Apurva Reddy or somebody said that. Could it be, if pain is a feature, is pain a feature of polymyositis? We discussed this last couple of meetings.
yes.
Is it a feature? No.
10%.
Only 10 to 15%. So how will you classify polymyositis? Etiology wise, what are the 4 types of polymyositis classification? Inflammatory myopathies are 3 types. Okay.
Yes, polymyositis, inclusion body myositis, dermatomyositis.
If it is polymyositis, what are the 4 categories?
Polymyositis, it can be due to mixed connective tissue disorder or malignancy, underlying malignancy, idiopathic polymyositis, autoimmune polymyositis.
No, dermatomyositis.
Dermatomyositis.
So idiopathic polymyositis, dermatomyositis, polymyositis secondary to systemic connective tissue disorders, and secondary to underlying malignancy. These are the, so we don't know, but 4 years is unlikely to be related to possibly not a malignancy. That's one clue we can get. Okay, can go on to the next.
Then she developed this symptom where she is unable to get up from the bed, and also while falling, she is like when she's lying down, she falls onto the pillow. This truncal weakness and neck muscle weakness, and then she noticed thinning of her arms. So there's wasting. Initially, she felt her blouse to become loose. The wasting of the muscles also was present.
Okay, carry on. So this we have already mentioned.
Yes.
So people can just go through this. And anybody wants to ask any more questions about the localization or etiology history? Any questions are required?
Whether she had any relieving factors of the pain. He said it is throughout the day. So waxing or waning.
No, sir. No
history
fluctuations. No waxing, waning, sir.
and any relieving factors.
So
of
she
the
said
pain.
that when she goes to bed, the pain used to reduce.
Did she have proper sleep?
Yes, sir. She had a proper sleep. She never had night pains.
Right.
Somebody is asking any discoloration of urine, sir. I think Dr. Sant.
The other thing was whether she had any tenderness at any time. All these
No,
pains were there.
no, sir. She only felt cramp-like feeling at
Yes. So
times.
normally when they have cramps, they start massaging, no?
Yes, sir.
They ask somebody to massage them. So did she have increased pain or decreased pain, or did she not try it at all?
So she did not have any relief. She said she had applied cold ice she had applied, but then with that there was no relief. Massage, I didn't ask her.
Why, why can't it
Good
be radiculopathy or anti-Honsel? Anti-Honsels are silent. Radiculopathy features are not there in this pain.
Hello, good evening to all of you.
Hi,
I'm
sir.
Dr. Sinha here.
Welcome,
Hi,
sir.
good.
Welcome.
Yeah.
Welcome.
One part is very nicely presented, but would you like to explain, did he have any problem with the bulbar muscles, swallowing,
No, sir.
blowing?
You show the slide. Go back to the slide.
Yes, there was no difficulty in swallowing, no nasal
Okay,
regurgitation.
you have put it there. Okay, fine. Good.
So
Okay, good.
now we have muscle weakness and pain. 4-year duration. Somebody is asking me any discoloration of urine.
No, sir. No urinary discoloration.
Somebody is asking, was the weakness progressive?
Yes, sir. Gradually progressive.
Yes.
That's is it symmetrical? Dr. Sant sir also asked, and it was so told that symmetrical onset. So any clues? Now past history is nil relevant. Go to the next slide.
So family history, there's no similar complaints among family members. She was born of a non-consanguineous marriage. Normal vaginal delivery conducted at home. There was normal childhood, no regression in developmental milestones. Personal history, diet is mixed, appetite normal, sleep is adequate, and no addictions.
Any significant gynec obstetric history?
No, sir.
You have to mention that. In the ladies, you have to mention.
So she had 2 abortions,
Hmm.
miscarriages, both were at 6 months. She was told that there was reduced blood flow in her uterus. This is what she said. And because of that, they had to terminate the pregnancy. She had 2 miscarriages.
Any comments on the family tree? Shall we go ahead, sir?
What about drug history?
So no, she's not on any medications.
Ayurvedic medicines or something?
No, sir, nothing. She used to apply local. Yes, sir, I had asked. She used to apply only local balms, tiger balm. She said. Otherwise,
No. Before the problem started.
4
No,
years.
sir.
Was she taking any? Sometimes they take for stomach problems or joints or whatever.
No, sir. She was not taking any medicines.
Dr. Ram is asking, is symmetrical onset? What do you want to know, Ram? If it is symmetrical onset, what is crossing your mind? Pseudo-autosomal recessive pattern. Dr. Garpati, I am not aware. If anybody can answer, I'll be happy. I never learned this. Anybody? Opposing? Not able to follow this. Opposing for AHC. AHC, no fasciculation seen. Pain is not a feature of
The pain goes against.
not a feature of anti-hostile disorders. There is no radicular pain. There are no features which suggest that aggravation occurred with raised intracranial pressure features. So all these things are against radiculopathy. Okay, next slide.
So to summarize, we have a young female with insidious onset, gradually progressive quadriparesis, proximal onset and then distal also involved, with truncal and neck muscle weakness, with wasting of her hands and legs, with no cranial nerve, sensory gallbladder, or autonomic involvement. Functionally,
You said she had pain, no? And now you're mentioning only motor problems.
yes, sir, she had pain. So I thought like muscle pain.
Your presenting symptom was pain. The patient started with pain. So to summarize, you have to say the patient started with pain and then developed progressive quadriparesis.
Yeah,
Yes,
diffuse aches and pains of the body. You also said cramps, no?
Yeah, you have written
yes,
here
sir,
no
cramp,
sensory
like,
involvement. How can that be?
So what do you mean by cramps? What is the pathophysiology of cramp?
cramp is like localized uncomfortable contraction of the muscle, and it is usually sudden and involuntary, and so it gets the region gets palpable. Origin will be like in the motor axon.
Okay. Then what is the reason for cramps? In what diseases you see cramps?
Sir, it can be seen in commonly it is seen in pregnancy, dehydration, in dyselectrolytemia, hypothyroid. Then
Please tell some neurological disease where you get cramps.
some motor neuron disease, myotonias, muscular dystrophy.
Muscular dystrophy.
You get cramps in dystrophy? No.
So myotonias, myotonic syndromes, neuromyotonia, stiff person syndrome.
Somebody said periodic paralysis.
No, so channelopathies.
Okay.
Have you heard something called cramp fasciculation syndrome?
Cramp fasciculation. Yes, sir.
Did you read about it?
9 fasciculations with cramps.
So which are the metabolic conditions where you get cramps? Common ones?
Hyponatremia, hypocalcemia.
Hypokalemia.
Hypocalcemia.
Calcemia. Calcemia, you get tetany, no?
Tetany.
Yes, sir.
Sports people, they get cramps because of what? Runners and tennis players. And
have you heard of any metabolic myopathies which produce cramp? That's what Dr. Sant wants to ask.
Yes, sir. Metabolic myopathies, they can be carbohydrate metabolism related, sir. Like McArdle's disease, then phosphofructokinase deficiencies, then acid maltase deficiency. Then there can be lipid metabolism deficiencies, CPT1, 2 deficiencies.
I think fair enough. Shall we go ahead?
Yeah.
Shall we go to the findings or any more discussion you want to say? Anybody wants to ask any more questions?
So from history, you think it is acquired or inherited disease?
Sir, more likely like inherited, I'm thinking, because she's young and
so young patient don't get acquired disease?
How many years duration?
4 years. It has only been 4 years.
So if you say inherited, which inherited disease you're thinking?
Some
You also mentioned muscular dystrophy. And what is the definition of muscular dystrophy?
Dystrophies are muscular dystrophies, so genetic myopathies where there is necrosis of muscle fiber and
No. Muscular dystrophy, clinical dystrophies. What are dystrophies? Anybody can tell the clinical definition of muscular dystrophy. Right from beginning, Dr. Sant is asking a question. Somebody else also has asked a question.
so like there is a disturbance in the structural protein of muscles, and that causes
That is your general intelligence that is telling. What is the definition given? It's a progressive, inherited disorder. It's a progressive, relentlessly progressive, mostly symmetrical, inherited. That is muscular dystrophy. Do you think it is an inherited disorder?
Yes, it is. It can be.
If you say this is inherited muscular disorder, which one you are thinking of?
So inherited, like one we can see like dystrophinopathies.
Female. Wait. You are saying a female who gets dystrophinopathy.
No. So males that is seen X-linked. So
No. Now we are talking about this lady. Now you think that this lady who has got a progressive weakness, which is proximal, then you say distal and neck and wasting. So you need to tell us a muscular dystrophy in a female where there is a distal muscle also involved, neck is also involved, and you get wasting within 4 years of onset.
Correct.
So which is this myopathy that you're thinking? Tell us. You just don't tell everything in general. Now you have findings. So according to finding, which one? If you say this is myotonic dystrophy, if you say this is facioscapular, examiner is not going to help you. You need to tell us, depending on this patient, which one you're thinking.
So it can be limb girdle muscle dystrophy. It can be.
So do you get neck? Wait. Do you get neck weakness in limb girdle muscular dystrophy?
So what are the causes of leg muscle weakness? You just revise them.
Neck muscle weakness, myotonic dystrophy, motor neuron disease, myopathy.
What else? See, important causes of neck muscle weakness. One, you said.
Congenital myopathies.
What are you talking, man?
Motor neuron disease, myotonic dystrophy.
Yes. What else?
What else?
Two causes you said.
Facioscapulohumeral.
No. Too much.
See, what are causes means come out of muscle and think all causes.
So motor neuron.
This is you said already.
Correct.
What else? Myasthenia gravis.
Myasthenia gravis. And
CIDP,
some poisoning.
AIDP.
Poisoning.
AIDP, CIDP, botulism is myasthenia gravis.
So neck muscle weakness, if you identify, your differential diagnosis narrows down.
It narrows down. Yes.
And now you are thinking of muscle. So out of these muscle causes, what could be the most common cause? So as Rahul is pointing,
polymyositis.
Yes, inflammatory myopathy is one cause.
Then myotonic dystrophies.
Yes. Good.
FSHDs.
So see, if you are talking about myotonic dystrophy, then in your history you have to come out with other problems, with other endocrine, balding, etc.
The most common three
all
myopathies.
these things should come in your history.
Yes. The most common three myopathies. Sorry, sir. The most common three myopathies which will have neck weakness is inflammatory myopathy, Duchenne's muscular dystrophy, and myotonic dystrophy.
So out of these two, one is out. Duchenne is out because she is out.
Yes.
So is it inflammatory myopathy?
Do you think this is inflammatory or do you think this is myotonic dystrophy?
The myotonic dystrophy.
Rahul is presenting, so he knows.
Achha. So you think this lady has myotonic dystrophy without any cranial fissures, without any... so in myotonic dystrophy, where is the weakness more? Proximal or distal?
Exactly.
Is there a distal myopathy?
In myotonic dystrophy, is it more proximal weakness or it is more distal weakness?
And in natural history, how soon does the weakness start after the onset of the disease?
Type 1, so there will be distal weakness. and it is more
Yes.
severe.
Type 1 distal, 2 proximal.
Yes.
I
Type
think
1 is more severe disease, like
So this
early
lady, you think it
teenage.
is type 2, is it?
Like possibility.
Okay. So
Because
if you say,
in adulthood she has developed.
so what
But
is usual the age of onset of myotonic dystrophy?
so in teenage, usually in teenage they develop. So
Can it occur at
early
birth?
teenage.
Can it occur at birth? Can it start in 40s? Myotonic dystrophy. Can it start at birth? Can it start in 40s? What depends?
Type
What is the factor that decides the age of onset?
Hmm.
so that anticipation will be there
Not
in
anticipation, the number of repeats.
Anticipation, that is
The
different.
number of repeats.
repeats.
The more are the repeats, the earlier is the presentation. So, we had patient where it can present at birth also, which is called as congenital myotonic dystrophy, where they have highest number of repeats, while it can sometimes start in 40s and 50s also. Which patients, these patients have usually less number of repeats.
so. What is this lady's age?
You can't say that
27.
it starts in teens.
27 years.
The myotonic dystrophy can start depending on the number of repeats.
Genetic
Okay.
anticipation, trinucleotide repeat disorders.
What's it?
Rahul, can we go ahead?
Yes, no, I'm just asking. He has written his etiology,
Myopathy.
myopathy, acquired versus inherited. So I'm asking which are the acquired that he's thinking, which are the inherited that he was
Yes.
thinking. So I mean, rather than acquired inherited, one
Or, yes.
this acquired I'm thinking, this inherited.
Yes, I think that's a good discussion point.
Yes, sir. For acquired, I was thinking more like inflammatory polymyositis, inclusion body myositis.
But
Sorry,
do
not
you think
inclusion.
inclusion body myositis in this age group?
No, not inclusion. Polymyositis or some other mixed connective tissue disorder leading to polymyositis versus inherited like this.
I think Rahul, that's good. No, either it is acquired or inherited. Acquired, you got two differential diagnoses. Okay, I think carry on with the next present. Aage
Yes.
badho. Go ahead.
So general physical examination. Patient is conscious and oriented to time, place, and person. Pulse was 82 beats per minute regular. Right radial artery with no delays. Normal character and condition of vessel wall. Blood pressure was 118/80. Respiratory rate was 14 per minute. No pyelectrus, clubbing, cyanosis, lymphadenopathy. No neurocutaneous markers. She had dysmorphic faces. She had a long face with hollow temporals, and there was crowding of teeth, also low set ears. Her neck muscles were thin and long. Also had poor dentition with tooth decay, no cataracts. Neurological examination, high mental function is normal, speech language is normal. Cranial nerve examination, she had on examination bilateral element facial weakness. She had weakness in closing the eyes and unable to also blow air in the cheeks. But taste was intact. Vision, okay, 2, 3, 4, 6 were normal, sir.
You think is facial muscle weakness or facial nerve weakness?
Facial muscles.
Okay. But did you find any Bell's phenomena to say that it is element?
So there was no Bell's phenomenon,
Then-
but on opening the closed eye, she was not able to keep it closed. It was easily opening.
There is a facial muscle weakness,
Orbicularis ocular.
So maybe you have to correct yourself there. Unless Bell's phenomenon, bilateral facial element to diagnose, you have to say Bell's phenomenon.
Yes. Also, she had truncal weakness. Otherwise, and the muscles of neck were atrophied. The sternocleidomastoid and trapezius. Tongue was normal with no deviation, no fasciculations or atrophy. Motor system, there was wasting in bilateral thighs, calves, and arms, loss of muscle control was there, increased guttering. Tone was decreased in all limbs. Upper limb, shoulder, flexion, extension, abduction, adduction was 4 bilaterally. Otherwise, elbow flexion, wrist flexion, pronation, supination was normal. Lower limb power was also hip was more affected. So hip about 4 in bilaterally. Knee flexion, extension was 4. Reflexes, so they were present but diminished. Biceps, triceps, knee, and ankle was present. There was no clonus.
Where is neck muscle?
So neck muscle was weak, sir.
So there where you have
Flexion
mentioned
extension.
your history and your whole diagnosis is
These are
based
neck
on
muscle
neck muscle
weakness.
weakness.
Yes.
He didn't mention this. You had to mention neck muscle, no?
Your whole diagnosis is based on neck muscle weakness, isn't it?
Yes, sir.
So you should have said neck, you should have said truncal. Those things you need to increase, include in this. Just not saying that upper and lower limb is not sufficient in this case.
Yes, sir.
Yeah, please go on.
There are 3 videos of examination of the tongue. There was myotonia, sir.
You're not able to clearly see this.
And also hand grip, there was percussion myotonia.
Did you demonstrate slow release of hand grip?
Yes. Is it visible?
This is visible. Any other videos showing?
Her gait video is there, sir. There's a waddling type of gait.
You have taken permission?
Yes, sir. I've taken consent.
Can you name the myopathies which have myotonia?
Myotonic dystrophy, type 1, type 2, then paramyotonia, myotonic congenital, then channelopathies, then
So these are all channelopathies.
neuromyot. Yes, sir.
Any disorder where there is a damage to the cartilage and myotonia?
Which one, sir?
Any disorder where there is a damage to the cartilage and patient have myotonia? Have you heard of any condition?
I don't know.
I think you can tell Rahul. They don't know, I think.
There is a myopathy which is called as chondrodystrophic myotonia, where there is a damage to the cartilage and they have myotonia. It's a rare kind of myotonic dystrophy. It's a rare kind of myopathy where there is myotonia. Plus, they also have got bony disorder where there is a damage to the cartilage. The cartilage is not developed. So, this is called as chondrodystrophic myotonia.
Very nice. Excellent.
Chondrodystrophy. Okay.
Age-old condition. Yeah. So, now tell us, how do you differentiate between myotonia, pseudomyotonia, and neuromyotonia?
Myotonia.
You would all know the genetics. You would all know everything. So examiner is going to ask you a question like this only.
Yes. So they neuromyotonia, like they usually have it like resembles fasciculations, and they might have like twitching at rest also.
That's a hand grip I'm asking. Did you show hand grip?
Hand grips actually power was good, sir. Both bilateral it was.
Did you demonstrate slow relaxation?
Yeah, percussion myotonia was this.
Okay. There is slow relaxation of hand
Yes,
also.
yes, sir, slowly. In this video, I think it is.
That is only it's not slow relaxation of hand grip. You
So
have
it was there, like when I examined, it was there. I didn't take video.
you didn't put it up.
Yes.
It may only have grip myotonia in pseudomyotonia. Any other differentiating feature? Delayed relaxation of muscles, it is there in this case.
Mhm.
And hyperexcitability neuromyotonia. Somebody said cold sensitivity. Warm-up phenomena. Who is this? Can you describe this? You can unmute. You can talk. How will you differentiate? Who is the DG? Okay. So how did you next? What else?
The sensory examination was normal, sir. Spine was normal, no tremors, no thickened or enlarged peripheral nerves. Cardiovascular system, there was no murmurs. S1S was normal, and respiratory system and autonomic system also normal.
Okay. So did you do investigation? Want to show anything else?
Yes, after this we did some blood investigations. CPK was just raised 420, and TFT thyroid was normal. Electrolytes were almost normal. Hemoglobin 11.5. Then we did NCV EMG, sir. In EMG there was myotonia was present with myopathic pattern.
There's no sound.
Any others?
We are not hearing the sound. Audio is not there. No, no.
Mm.
How do you describe the myotonia on EMG?
Dive bomber, like it sounds like dive bomber or motorcycle.
And what are these discharges? Are these MUPs? What are these?
So this is on spontaneous activity.
Insertional activity,
Insertion
not
and
spontaneous.
spontaneous.
As soon as you insert, you get dive bomber. Then what did you do with the hammer?
No. So what are these waves? They are MUPs or what are they?
Motor units, continuous firing of motor unit.
No. These are motor units which are firing.
Spontaneous.
Motor units are firing.
Like discharges, like from the muscle, like spontaneous.
No. What are these?
Activity. What are
Which
the
discharge are
spontaneous?
these?
Uniphasic है, biphasic है, triphasic क्या है? MUP is a triphasic response, right? So just go back and see what it is.
What type of spontaneous activity is this? Myotonic discharges.
Mhm.
What are the spontaneous activities you come across on EMG?
Fasciculations, fibrillations, positive sharp waves.
And fasciculation potentials and
Positive sharp waves, no? Fibrillations, CR.
What is the CRD? Tell us, huh?
CRD complex repetitive
discharges.
discharges.
Okay, now if you say that this is myotonic discharge, tell us something about how does it appear, how does it disappear? Will it come abruptly? Will it go abruptly? How does it increase, decrease? Tell us something more about these myotonic discharges.
Yes, on doing like on percussion, it was present.
And no, on EMG, we are talking about EMG now.
As soon as you put a needle, you got the disc. Then what else you did?
Then we look for MUP, whether there's recruitment that was reduced.
Yeah,
And-
you forget
Wait.
Insertional activity only. You talk about the
You're talking
myotonic
about
discharge.
myotonic discharges. Tell us something more, na?
What sweep speed you keep for the myotonic discharges
Correct.
to demonstrate it properly? You described, no? You said it was waxing and waning or something.
What happens to
like
its amplitude? What happens to its frequency?
It eventually wanes off. Amplitude is persistent as
no.
long as it is there.
So why dive
What's-
bomber is called?
that. It is
So it
waxing and
sounds
waning.
like-
It is not persistent.
Yes, it sounds like the missiles that were in World War that were being launched, like the dive bomber.
I think Rahul, you tell them.
So they would be waxing and waning in both frequency as well as amplitude. So
Yes.
if you increase the sweep speed, you will see that they are going up and down.
You
The
keep to
amplitude also
100.
increase and the
Keep
frequency
sweep
also
speed
increase.
100.
Yeah. So it will go up, it will go down, it will go up, it will go down, and the frequency also would change. If you change the sweep speed, you will see it. So you need to just, once you do the recording, you should change the sweep speed and see the entire unit or entire discharge, or maybe more than one discharge in one go. And then that actually on the screen, you will see that it is increasing and then it is decreasing. That's what you should do. Okay.
Right. That's nice.
So that's number one. Number two, you will also look for whether there is evidence of myopathy in this patient, right?
Yes.
Yes, so that
So-
was present. So,
Yeah. So
MUP, it was like recruitment was there, and there was small amplitude, and interference was complete.
right. So if you do EMGs, suppose in patients of myotonia congenita, will you get this dystrophic pattern also?
Yes, sir. They will have myopathic pattern also.
Are you sure?
You're not telling. I think you need to read, Hari.
Okay.
All right. So now we finished. I hope you have finished the case.
Yeah, case is over, almost over.
Yes, sir. That's it.
Anything else you want to
So
say?
what did you check any other systems in this lady apart from just the
Cardiac-
neurology and the musculoskeletal?
Cardiac, I checked, sir. ECG was actually normal. Even examination was normal. ECG was also normal. No murmurs.
Mhm.
She didn't have any palpitations history.
So normally, if what kind of cardiac problem you expect in this lady?
So they will have arrhythmias, and they can have cardiomyopathies.
Which kind of cardiomyopathy?
Heart failure, they can have.
No, what is the most common cardiac abnormality that they'll have?
Tachyarrhythmia, so they have. And cardiomyopathy.
What type of myopathy? Cardiomyopathy, dilated cardiomyopathy.
Conduction problems will be there.
Cardiomyopathy, what type?
What are types of cardiomyopathy you know?
Hypertrophied cardiomyopathy, dilated cardiomyopathy.
So what do you think will happen in this case?
I have to.
Well, somebody's written already. Hypertrophic. How come?
Hello, anything else in the eyes you would look for it?
Yeah, eyes. That's for second thing.
He mentioned in
additional thing you see in eyes?
examination, but you can ask again. Yeah, what are the things
Okay.
you realize? What are the things you look?
Early cataracts, retinitis.
Did you see for cataract?
Mhm.
So there is no cataract. We have
That
checked.
he mentioned.
Did you mention that?
Yeah,
Yes,
yeah,
sir.
you mentioned.
Okay, sorry.
The cataract is especially mentioned as a posterior capsular cataract, unlike the other one.
Good.
Fine. So you have to especially look for a slit lamp examination for the eye.
Uh-huh. So this is the first case of myotonic dystrophy for Harry, because this case was missed by many people and she came only with body aches. So he got foxed and then he could somehow come to the diagnosis. Any other comments?
Yeah, but
So
in
now
his
tell us-
in your history, Srihari, I would like to make one or two comments there.
Yeah, please.
If once you have made a diagnosis of myotonic, go back in history and add all these points.
And yes,
Dyspnea,
slow relaxation.
endocrine, menstrual problems, all these things you have to add. You may not have asked in the beginning, but
Yes,
once you have reached a diagnosis, go back and add it to your history and then present.
that's what is required. You have to knit up a good story. Once you know the story, go back and write the history again. Last time, Dr. Sudhir also was telling the same thing. If you know this, you go back and construct a story.
And at the end of your history itself, the diagnosis was pretty clear.
Yes.
4 years history of upper limb, lower limb, distal, proximal followed by distal, and neck weakness and wasting. There is no other myopathy which will present in this way. So diagnosis was looking at our face even when you presented the history itself. Forget about examination.
Yes.
There is no other differential. In this case, you don't get wasting so early in other myopathies. You don't get neck, upper limb, and lower limb weakness in any other myopathy like this. So it has to be myotonic dystrophy. No other differential.
And one important point for all the residents is neck muscle weakness. Please remember the causes so that you should not forget to write in the examination also.
Yeah. Last question. Tell us something about other myopathies which have cardiomyopathies, and which cardiomyopathies do they have? Or cardiac involvement in muscle disease. Let's see. Let's put it a little broader. Cardiac involvement in muscle disease. Tell us something about it.
Usually they have some conduction defects. Then
no, what myopathy?
Name each disorder. Name each disorder and name the associated cardiac problem with it.
Right.
You are seeing this mostly in the children, so now you try to recall. Hint there. One of the commonest
What
ones.
is the commonest muscular dystrophy in children?
Yeah.
And what is the
Duchenne
muscular dystrophy? Yes. And what does it have?
Duchenne and Necker, sir.
What type of myopathy? Cardiomyopathy.
I have to check.
Dilated cardiomyopathy.
Dilated.
Cardiac failure.
They develop cardiac failure, fibrosis.
Emery-Dreifuss muscular dystrophy. What type of this thing you have?
Emery-Dreifuss.
Heard of Emery-Dreifuss or no?
Yes, sir. Excellent. They also have sudden death. Atrial effect. They require pacing, sir. Emery-Dreifuss. They'll have atrial.
Arrhythmias. Okay, good. Conduction blocks.
And like females are requiring screening. They require screening in female.
Any other limb girdles which have cardiac involvement? Common limb girdles which have cardiac involvement?
Interesting.
Heard of any limb girdle myopathies with cardiac involvement?
Something is written also there.
Dystrophinopathies. Titin related.
Yes, titinopathies can have cardiac involvement. Then
Sarcoglycan
can have cardiac involvement. Yes. Then
somebody wrote dyspharin and fukutin.
Fukutin is not a limb girdle myopathy, but yes, FCMD will have cardiac involvement, of course, but it is not a limb girdle myopathy by traditional definition.
Somebody wrote telithinopathy.
So you need to read,
Yes.
all these. You need to see whether in Capen there is cardiomyopathy, in laminin there is cardiomyopathy. You must know this, And then the additional myopathies, as he's saying, FCMD, there will be cardiomyopathy, of course. Mitochondrial, there will be cardiac involvement. Yes.
Mitochondrial,
So you must,
very important.
Mitochondria. Actually, can myasthenia gravis have myopathy, cardiac involvement?
Yes. We had a patient recently who looked like EDMD, Emery-Dreifuss-like phenotype. We did his workup and it turned out to be that he had a titinopathy. So we labeled him EDMD phenotype like presentation of titinopathy. And this boy, he had a cardiomyopathy. 1 year later, he presented with right MC infarct. So he had a cardioembolic infarct, which came from the cardiomyopathy, and he had a baseline EDMD myopathy. Like presentation, this was all titinopathy. So he is a titinopathy who presented with stroke as well as EDMD-like phenotype. Typical contracture of neck and elbow.
Very nice, very nice.
So he's been following up with us. We are in the process of writing this case. So,
Excellent.
So we must work these patients up. Huh?
Yes. And Dr. Ahuja from AIMS have described myasthenia gravis with cardiac involvement.
Again, that's a rather debatable issue, I must tell you. When we were residents, we read this paper, and there was a lot of debate about cardiac involvement in myasthenia gravis. It's a pretty old paper. We know that study, but it's a rather debatable issue, I must tell you. We had an extensive discussion on this cardiac involvement in myasthenia, but it's I must say it's a debatable issue.
If at all, it is pretty rare, isn't it?
Yeah, I just mentioned that there is a paper by him. I said whether it is.
Yes.
It was a thesis of, I think, Dr. P.P. Ashok.
Acha, Ashok. Oh.
Yeah, Ashok had done a thesis. I remember because 20 years back we had done an extensive review on this subject, and then it turned probably that it's a rather ambiguous entity.
Yeah, absolutely right, Dr. Kulkarni. See, when you say myasthenia, it is basically myoneural junction problem. It is not a muscle problem as such. And so far the cardiac muscle movements are concerned, it's not a muscular problem, it's a myoneural problem. So, well, I have not come across or read about the heart problem and myasthenia gravis as such.
Good. I think the essence of this clinic is all the residents should know more about myopathies. They should read extensively. Greeks think myopathy, muscle disorders is a book recommended. But I think you better start with Harrison only, then go to Bradley and read thoroughly all the myopathies. And I think
if you get an examiner from Mumbai, usually they are people who are very strong in myopathies. So you have to be ready in myopathies.
Lucknow also.
Lucknow also? Yes. And we don't know.
Yes.
Sunil Pradhan aa gaya. Satish sir, then there will be a lot of neuromuscular. I think we had a good discussion. Shall we wind up?
Yeah. Thank you, Dr. Gorthi and all the team. Thank you, Dr.
Rahul. And next week, somebody, Rahul, can your team present any case, discuss?
Yeah, our resident probably he has a case. He has a nice case. He was, I think, ready, but then hopefully next time he should be able to present.
No, next time
one of them had to go for that summer school, so there was an issue with the resident number of residents available. But next time, yes, he will definitely present.
Next Friday is going to be Rahul's. No, okay, that we fix. Then we can think of others. Sudhir also will come back and they'll have a case. Okay, then. Good night. Thank you very much.
Thank you.
Good night.
Good night. Bye bye. Yeah.
Thank you.